Hello, friends and colleagues out in YouTube land. This is Dr. Reeves, bringing you another neurology teaching talk. This one is about how to think about people who have a neurologic spell. So it's a thinking algorithm and not a testing algorithm. I hope at the end you'll be able to tell a seizure from syncope or fainting, from psychogenic falls and collapses from maybe some other stuff. So let's get right to it. The differential diagnosis of a spell is some kind of syncope or fainting, seizure, psychogenic event. Yes, there's a list of other stuff, migraine and TIA and other things that can cause people to kind of collapse and have odd spells. But they're really fairly uncommon. TIA often surprises people when I say that. But in order to have a TIA or stroke that makes you go unconscious, you have to pretty much block off the blood flow from the basilar artery to get the brainstem to shut down. And people do not look good when that happens. And so when someone comes in and says, well, I had this spell where I collapsed and there's a gap in my memory, and then 10 minutes later, I was fine. A carotid artery circulation stroke or TIA doesn't do that, period. A basilar one can do it, but they usually have lots of bad neurologic problems with that. So in the ambulatory setting, that's usually not so much of a consideration. Let's talk about the profile for the event. And this is really kind of where we get the takeoff for the algorithm. We're going to divide the event into a prodrome, the event itself, and its aftermath. We're going to talk quite a bit about the prodrome, quite a bit about the event, less about the aftermath. But these are the three things that I take the history on when I'm trying to figure out what kind of neurologic spell was this. Were they fainting? Was it a seizure? What? So we're going to really grind through it. We're going to start with the prodrome. If the prodrome is the prodrome of syncope, they may have no warning at all. They may just say, bang, it hit me. Very typically, they tend to be upright, but occasionally they were on the toilet or just sat down or something like that. Or the prodrome before syncope can be one of minutes, building up over 2, 3, 5 minutes. I was getting worse and worse and worse, and then I passed out. The prodrome of seizure also ranges from nothing to tens of seconds, not minutes and minutes or half an hour, because the prodrome of a seizure is, in fact, seizure activity. It's just seizure activity that's not really spread very far in the brain. And so the person had some symptoms, but the seizure disorder hadn't spread far enough to change their memory so they could remember it later to tell you about it. But it's still a seizure, and they tend to last tens of seconds. So 30, 50, 60 seconds isn't uncommon. A 2-minute prodrome that turns out to be seizure, well, you'll see that sometimes. That's getting a little bit on the longer side. When someone says, well, I can tell when I'm going to have a seizure because I have X, Y, or Z symptoms that built up for 30 minutes, I say, well, it's probably not a seizure. Psychogenic prodrome, anything from nothing happened to hours and hours, or occasionally even days of increasing symptoms. The syncope prodrome very often has components where the person will say, I felt hot or I felt cold, I was sweating, or I had tremors, I was shaky, lightheaded or dizzy. Some people will throw up or just feel nauseated. Sometimes they will describe not just the classic tunnel vision where you lose your peripheral fields, but some people will talk about, I had swirling sparklies in my vision, or I had black dots in my vision. Other people will talk about muffled hearing or ringing in the ears, building up before they collapse with their spell. To me, that suggests it was more likely to be syncopal, particularly when it built up over several minutes. Seizure prodrome, as I've already mentioned, is a seizure. It just hasn't spread that far. And it tends to be constant. It tends to be pretty much similar from attack to attack in a person who's had multiple attacks. Often it's difficult to describe because they're such unusual neurologic disturbances that we don't have an agreed upon word for those feelings. But again, they tend to last, from 0 to tens of seconds, but not hundreds and hundreds of seconds, most typically. The psychogenic prodrome, all bets are off, quite variable, but some prodrome symptoms make us feel like seizure and syncope are much less likely. And that's the person who has hours of symptom buildup. That's also in the person for whom the prodrome symptoms are like headache or pain somewhere. That would be very uncommon with seizures. And certainly building up over a long period of time like that would be very uncommon for syncope. Now let's talk about the event itself. There are 3 critical aspects to ask about once you've kind of ground through the prodrome. And I literally, when I'm taking the history, starting with the prodrome, I'm asking, well, how many seconds did it take to go from A to B to C symptoms? And we really kind of map that out. And then we get to the event itself. There are 3 things I want to know above all else. I want to know if they collapsed to the ground, was it because they had an initial loss of motor tone? They lost tone and they went to the ground sort of like a sack of potatoes, like we say in the United States. Sort of, they went to the ground because they became limp while their body was already upright, and so they sagged to the ground. Or did they go to the ground because they stiffened and they went over like a telephone pole? The second thing I want to know is, was there a gap in their memory? There's a portion of this event that brought them to my emergency room or my office or my hospital where they just don't remember. And the third thing I want to know is, to bystanders, during the event, did the person appear to be unconscious? So we're going to unpack some of those a little bit more. Initial loss of motor tone is kind of like I said, you go down because gravity pulls you down because you have lost the ability for your muscles to keep you up, as opposed to the person who has a convulsion and their muscles stiffen and so they fall down. With syncope, loss of motor tone hits right away. Very often people do fall to the ground and then stiffen, and it can look pretty impressive, like maybe a seizure. But you really have to ask about that initial 5-10 seconds of that's the time during which the person goes down. Now, what they do after they're on the ground is a bit of a different matter. Sometimes with syncope, they just are inert. They're lying there still. Sometimes they stiffen. But regardless, it's why they went down. Loss of memory encoding means loss of memory encoding at the time of the event. There are sometimes patients who come and say, I think I'm having seizures, Dr. Reeves. Well, why is that? Well, I have gaps in my memory, which does sound worrisome. I don't collapse, but I have gaps in my memory. And they'll describe that they went somewhere and they did something that requires maybe driving a car, interacting with people. I went to the grocery store and I bought milk and I bought bread, and then I came home and I put the milk in the refrigerator. I put the bread in the cupboard, and they'll say to me after that, I have no memory of doing any of that. And so they often describe a pretty long gap in their memory. But they're also saying that, well, during that time, I behaved normally. I was able to interact with the clerk at the store. I was able to put the milk in the refrigerator. And so that's somebody who's talking about an after-the-fact memory gap. They're not talking about a neurologic attack like we're discussing today. True loss of consciousness is seen with syncope and generalized tonic-clonic seizures, but it doesn't occur in complex partial seizures. Rarely would it occur in TIA, and it really doesn't occur in migraine. The psychogenic events, apparent loss of consciousness, can occur. People appear from the outside to be unconscious, and that means that they are not responding to normal external stimuli. So let's talk about this. This is the grid that I use when I'm taking the history for a spell. I want to know about apparent loss of consciousness, loss of memory encoding, initial loss of motor tone. If it was a seizure, complex partial seizures, they do not appear to be unconscious. They are behaving abnormally. Sometimes they're staring or fidgeting. They might be walking. They might be doing something else, but they are doing something. They are not lying in a puddle on the floor. There is a gap in their memory, but they don't have any loss of motor tone. If the person has a seizure and it is a generalized tonic-clonic seizure or a convulsion, they do indeed appear to be unconscious. There is indeed a gap in their memory, so they have loss of memory encoding, but they actually don't have loss of motor tone. As I said before, they have got lots and lots of motor tone. That's why they go down. With syncope, you get all three plus signs. They appear to be unconscious during part of it. There's a gap in their memory during part of it, and they go down because of loss of motor tone. Psychogenic events, all bets are off. But there's a pattern that you want to ask about, because there's one pattern that I do see from time to time, and you have to specifically ask about. The person may come and say, well, I blacked out. And, oh, were you unconscious? Yes, I was unconscious. But I'll ask them, so you were just lying on the floor? Well, that's what they said. That's what the people said. Okay. So we have what sounds like loss of motor tone. And we have a person who appears to be unconscious. And I will ask them. Now, sometimes I have patients who have spells where they can kind of hear what's going on around them, but they can't respond. And sometimes the person will say, oh, yeah, that was it. I was there, and I could hear them off in the distance, but I just couldn't respond. So that's a person describing apparent loss of consciousness, loss of motor tone, but no loss of memory encoding. And that's highly characteristic of a psychogenic event. Now let's move to the aftermath of the event. When they're recovering from a generalized tonic-clonic seizure, a convulsion, people are out of it. They are wiped out. It takes a while to kind of reorient, start making memories that they can tell you about later, start interacting with people normally and recalling it. If the person tells me that they had a convulsion where they fell to the ground and they were shaking all over and jerking, and in 5 minutes they were sitting up talking to their wife, then I'm very suspicious that was not a convulsion. That's way too fast. People with complex partial seizures, of course, they don't appear to be unconscious. They don't fall to the ground, and so they more often will recover fairly quickly. But they often are tired, but not necessarily. Patients who have syncope tend to recover quickly when you restore blood pressure, blood flow to the brain, which occurs after they go from upright to lying down. Then the brain's getting more blood, and they recover pretty quickly, often within several minutes. And very typically they can say, well, I was only out for 20 seconds, and then I came to, and my family was there, and people were screaming, and somebody was calling the emergency services, and I felt terrible, and I was covered in sweat, and I was shaky. Okay, but they're describing that they felt terrible, they felt lousy, but they were back on planet Earth, they were making memories, and they were interacting with the environment. So their brain was, broadly speaking, functioning okay. That's a typical story for the aftermath of syncope. How do we evaluate all of the above? And this, I'm just going to really tiptoe through this. If you take the history of the prodrome and the event itself and the aftermath, and you say, gee, I really think this is probably a seizure. Well, you're going to get an EEG, awake and asleep. And if that's normal, you're going to repeat it at least once. And you're probably going to get a non-contrast MRI scan of the brain. And if you see something funny on it, you may need to do a contrast scan then. Okay. If you take the history and you say, gee, I think this is much more likely to be syncope, then at the very least, you're going to do a good set of orthostatic blood pressure measures. And if you don't know how to do that, I have a video on orthostatic hypotension. Please watch it. You're going to think about cardiac issues. You may have the person see a cardiologist, or you may do an echocardiogram, or certainly an EKG to look for conduction problems. And if they have recurrent episodes of syncope, and if they tend to be very abrupt, which is more characteristic of cardiogenic syncope, an ambulatory cardiac rhythm monitor of one flavor or another is often a good idea. If you think the episode may have been psychogenic, it's nice to try to record one. It's true of any kind of event, but it becomes particularly important if you think it might be psychogenic, because otherwise there'll be this lingering doubt about, is it the heart, is it the brain, is it a seizure? And that's where prolonged video EEG monitoring is so helpful, whether it be inpatient or outpatient ambulatory, or outpatient in the laboratory, where they come in and are recorded for a day. This is a judgment call based upon the characteristics of the patient's spells, how frequently they occur, and other factors. So I hope this has been a helpful, quick Cook's tour through a thinking algorithm about how to take the history of a neurologic spell. I have seen so many patients who clearly had a seizure, or clearly had a syncope, or clearly had a psychogenic event, and the wrong workup was embarked upon, often at the cost of thousands and thousands of dollars, and sometimes a substantial delay in the proper diagnosis, and sometimes the wrong treatments. But if you think about it clearly and you grind through the history, sometimes literally second by second, particularly in the prodrome, you can usually come to the conclusion that you know exactly what area you need to be investigating thoroughly. Thank you for your attention. I hope this has been helpful. Please leave any comments that you have down below. Subscribe if you like. Don't if you like. It's not a big deal. Thank you very much.